This is the narrative for Module L, the neurological system. Our nervous system, it contains two main parts. The first part is the central nervous system. This consists of your brain and your spinal cord. Then we have the peripheral nervous system. This contains 12 cranial nerves, 31 spinal nerves. The purpose of the peripheral nervous system is that it carries sensory messages to the central nervous system. So think of the peripheral as the highway that carries the messages back and forth to the brain and spinal cord. The cerebral cortex, this is the outer layer of nerve cell bodies, also known as the gray matter. This is where we create our thoughts, store our memories, develop reasoning, have sensation, and voluntary movement. The cerebrum, this is the brain as the whole. Our cerebrum is divided into hemispheres. We have a right and left hemisphere. The hemispheres are then divided into lobes. There's 4 sections. The frontal lobe, this is where the personality, behavior, emotions, and the intellectual functions. The parietal is the center for sensation. So this is where we can feel someone touch us. The temporal, this is the auditory reception center where we have our taste and our smell. And then the occipital, this is the visual receptor center. If we have damage to any of the specific areas that produce a corresponding sensory, if there's damage to that area, then you're going to have loss of that sensory or that sense. Here we have a picture of the different lobes that I was just speaking of. This is the cerebrum as the whole. We have our 4 lobes, okay? Pay special attention to the lobes and what each lobe is controlling, okay? So the frontal lobe, it controls our personality, behavior, emotion. The Broca's area, this controls the motor speech. So this is what is going to enable us to be able to talk. The temporal lobe, this is for hearing, taste, and smell. The occipital lobe, this is going to allow us to be able to see. The Wernicke's area, this is for speech comprehension. This is where we comprehend what someone is saying to us. The parietal lobe, this is for sensation, allows us to be able to feel touch. And then we have the cerebellum. This is where we have our balance, motor coordination, and our equilibrium. Going a little more in depth in the Wernicke's area, again, this is in the temporal lobe area, and this is associated with language comprehension. All right, so if this area is damaged, then the patient is going to have receptive aphasia. Receptive aphasia. This means that the person can hear sounds, but they have no idea what it means. So it's like they are hearing a foreign language or a language that they do not understand. The Broca's area, this is in the frontal lobe. This is associated with motor speech. So if a patient has a stroke or this area is injured, they are going to have expressive aphasia. This patient is not going to be able to talk. so they can understand what the nurse or family members are saying to them. They just cannot express anything back. This slide is just going over some more components of the anatomy of the central nervous system. The thalamus, this is the main relay station for incoming sensory pathways. It helps perform motor activities. The hypothalamus, this controls the temperature, our body temperature, sleep, emotion, automatic activity, and the pituitary gland. The cerebellum, again, this controls the motor coordination, balance, muscle tone, those voluntary movements. The brain stem, this is the central core of the brain. It contains the midbrain, pons, and medulla. And then the spinal cord. Remember, the spinal cord is the main pathway for ascending and descending fiber tracts that connect the brain to the spinal nerves. This is what I said is like the highway. The cranial nerves, they enter and exit the brain. The spinal nerves, there are 31 pairs of them. And the spinal nerves, they are named for the region of the spine from which they exist. So, for example, we have 8 cervical spinal nerves. The cervical are these up top, the top of the neck area. Then we have 12 thoracic, 5 lumbar, 5 sacral, and then 1 coccygeal. The reflex arc, this is a reflex that is involuntary. It's like a defense mechanism that our nervous system has. It allows us quick reaction to something that is potentially painful, harmful, or a situation that can be damaging. For instance, if you touch something hot, you quickly withdraw your hand from the surface. Looking at strokes, stroke is an interruption of blood supply to the brain. A stroke is the 5th most common cause of death in the United States. There is not one single factor that causes a stroke. Healthy lifestyles can help decrease the strokes. So we want to make sure we encourage our clients, not to smoke, eat a healthy diet, exercise, and maintain a BMI of less than 30. African Americans are twice as likely to have a stroke as white clients. This is due to geography and socioeconomic status. It could be due to lifestyle. So we want to make sure we encourage them to eat a healthy diet, exercise. Some other risk factors are diabetes and hypertension. So if an African American client has already developed diabetes or hypertension, that is even a greater risk factor, and so we really want to encourage and educate them on maintaining glycemic control and maintaining a adequate blood pressure. Subjective data that we want to ask about. We want to ask about any headaches. If they do, how frequent or how severe are they? Have they had any head injuries? If they experience any dizziness, dizziness is when they feel like that their head is spinning. And vertigo. Vertigo is where they experience the room moving around. If they have had any seizure activity. Seizures usually have two phases. We have the aura. This is before the seizure happens. And then we have the postictal phase. This is after the seizure has subsided. Do they experience any tremors, weakness in coordination? If they have any paresthesia, paresthesia is the feeling of pins and needles. A lot of times individuals will have this if they have diabetes and they have diabetic neuropathy. They can experience this in their legs and feet. Dysphagia with a G, this is trouble swallowing. Dysphagia with a S, this is trouble speaking. And we want to know about their past history. If they have had a previous stroke, this is extremely important. Any injuries to the spinal cord, if they've had meningitis in the past, if they've had any type of congenital defect, meaning a birth defect, alcoholism, and then any environmental or occupational hazards. So we're getting ready to collect our objective data now. So this is what we're going to collect when we do our assessment. There's a couple of things we need to do before we collect it. So you want to prepare. So you are going to make sure that you have the equipment you need. You're going to need a pen light, a tongue blade, some cotton swabs, maybe a cotton ball, a tuning fork, and possibly a percussion hammer. These are the tools to do a complete neurological assessment. To perform a neurological screening on a seemingly well person who has no subjective findings. But if it's somebody that has neurological concerns, you want to perform a complete neurological exam. So we'll go a little more in depth in class about the difference in a screening and a complete exam. And then you want to make sure you perform a neuro recheck on individuals that have neuro defects. So you're going to check those cranial nerves, the level of consciousness, pupils, the motor function, the cerebellar function, coordination, sensory function, and reflexes. So their mental status is important to assess. Some factors that can affect an individual's mental status is health problems. If they have an acute illness, an acute disease process happening, medications can affect it. Educational and behavioral levels, stress can play a part. Sleep habits, lack of sleep can decrease the mental status. Drug and alcohol use. Drugs and alcohol can depress the mental status. So the things that we want to look at when we are determining the mental status is their appearance, their behavior, and their cognition. The mental status, a lot of times this can be done when you're doing the health history interview. There are 4 main topics or key points that you want to make sure you assess for the mental status. Like I said on the previous slide, appearance, behavior, cognition, and their thought process. Appearance, you're going to look at that posture and positioning, their body movements. How are they dressed? Are they dressed appropriate for the season and their age, gender? Grooming, hygiene. You want to look at the pupils. Are the pupils equal And do they react to light? So when we look at pupils, we are looking for PERLA. Pupils equal round, reactive to light, and accommodation. So you want to pay attention to their behavior. Level of consciousness. Are they awake, alert, oriented? Do they answer questions appropriately? You want to look at the facial expressions. Are they comfortable? Do they make eye contact with you? Speech. Judge the quality of their speech. Do they have any slurring? Are they using adequate words? Their mood and effect. You can ask them, how do they feel today? Mood should be appropriate to, what's going on to the situation. To check the cognitive function, you want to check their orientation. Do they know where they are, the day of the week, year, season? Do they know their address, where they are currently right now, their name? Attention span. This is, can they complete a sentence? Can they complete a thought process without getting lost in that process? Recent memory, you can ask them to do a 24-hour diet recall, asking them what they had for breakfast or lunch the previous day. Remote memory, you can ask the person information, but you need to make sure that you can verify this information. You can ask about past health, birthday, anniversary, special dates. New learning, we can assess for their recall information, their memory recall. So how do we do this? We are going to pick 4 words. You're going to ask them to remember those words. Be sure that the person understands them. Have them repeat the words back to you. In 5, 10, and 30-minute intervals, you are going to ask the client to recall those words to you. Normal responses for individuals younger than 30, they get it right. They are able to recall 3 or 4 words after the 5, the 10, and the 30 minutes. Judgment. During the interview, you can ask about, job plans, social family obligations, any future plans, and what their health plan goals are. You want to make sure that the client's answers are realistic. The client's thought process and their perceptions. The thought process, you want to make sure that they are thinking logically, goal-directed, they're coherent and relevant. They should be able to complete their thoughts. What the person says should be consistent and logical. The client should be able to consistently be aware of reality. Perception should be congruent with yours. Screen for anxiety disorders. So you want to assess for any depression or suicidal thoughts. And to check for the cognitive function, we can do a mini mental exam. Now, the mini mental exam, this only concentrates on cognitive function. This is a good tool to help detect dementia or delirium. And it can be used to help differentiate these from a psychotic mental illness. A normal mental status average is 27. Scores between 24 and 30 indicate no cognitive impairment. The level of consciousness. Stimulation used to determine this is speaking, saying their name, Maybe we have to say their name in a louder voice. Do we have to touch them? Do we have to shake them? And then do we have to apply pain to get a response from them? So what we're looking for and how we document this is how does the person act when the stimulation stops? Okay, so are they alert? Alert means they are awake, aroused, oriented, aware of the situation. Lethargic. Lethargic is somnolent. They're not fully alert. They drift back off to sleep when the stimulation stops. So they're not very attentive to the situation. Obtunded. They're going to sleep most of the time. They're going to be very difficult to arouse. You are going to have to use a louder voice or you're going to have to shake them. They can be a little more confused when they first wake up. And they need that constant stimulation to stay awake. Stupor. This is a semi-coma. They are somewhat unconscious. They are going to only respond to that vigorous shaking or pain. They're going to withdraw their hand to avoid the pain that you are inflicting. And a coma is they are completely unconscious and you are getting no response out of them. Looking at muscle groups. Muscle groups, they need to be within the normal size appropriate to your client's age. They need to be symmetric bilaterally. It is okay to have about a 1 centimeter or less difference. Some abnormal findings is going to be atrophy. This is an abnormally small muscle. Hypertrophy, this is an increased size and strength, so larger muscles. And then we're going to have paralysis. This is loss of motor power, so they're not going to have any strength and be able to move their limbs. Strength, you're going to test this simultaneously in order to be able to determine. Coordination, can they move both hands at the same time? Can they walk without stumbling? Then you're going to assess the rapid alternating movements. You can ask the person to pat their knees with both hands, okay? Lift up, turn their hands over, and pat their knees with the back of their hands. And you can ask them to do it faster. Normally, so a normal finding, they can turn their hands over and have a quick rhythmic pace when doing this. You can also ask the person to touch their thumb to each finger on the same hand, starting with the index finger, then the reverse direction. Finger to nose test, and then the heel to shin test. To test the cerebellar function, we're going to test their gait, their balance. So you want to observe the person walking 10 to 20 feet, turn and return to where they started. The client should have a sense of freedom when they walk. Their gait should be smooth and effortless. Ataxia. Ataxia is an abnormal finding, and this is uncoordinated or an unsteady gait. Romberg test. You're going to ask the client to stand, feet together, arms at their sides. When they are stable, you're going to ask the client to close their eyes and hold that position for 20 seconds. A normal finding is they can maintain their posture and balance. If they begin to lose their balance when they close their eyes, This is a positive Romberg test, and this is an abnormal finding. So this is not good, it's abnormal. So a positive Romberg test sign, a positive Romberg sign is the loss of balance when they close their eyes. We're checking for sensation. Can they feel us touch them? So you want to make sure that your client is alert and cooperative, they're comfortable, and they need to be able to close their eyes. So you're going to inflict like a superficial pain. You're going to have an object that is sharp versus dull. You're going to have a light touch. Using a cotton ball, you can ask them if they feel the pain, if they feel the touch and what extremity, where it's at. You can also do a vibration test, and this determines the client's ability to feel vibration with a tuning fork, and this is done over bony prominences. Assess the sensory system again. Tactile discrimination. It's going to differentiate information through the sense of touch. First, we have stereognosis. This is recognizing objects by feeling their form, size, and weight. You place a key in somebody's hand and they are able to tell you what it is. Stereognosis. This is the inability. They're not able to tell you what that object is. Graphesthesia. This is the ability to read a number by having it traced on the inside of the hand or on the skin. So you open somebody's palm, you trace the number 3, they are able to tell you that you wrote the number 3 on the inside of their hand. Graphesthesia. This is they're not able to tell you what the number was. Kinesthesia. This is the ability to sense passive movement. The client's finger or toe, you move it up or down, and they are able to tell you which way you moved it. Paresthesia. This is the burning, tingling, or numbness. Deep tendon reflexes. You're going to compare right and left sides. The responses should be equal. You are going to apply a short, snappy blow with the reflex hammer, and it should cause the muscle to contract. How do we document this? So we have a scale from 0 to 4, and please note 2 is average. That's what we're looking for, okay? 0 is no response. 1 is very minimal response. 2 is normal, what you would expect. 3 is brisk. It's a little more than average, okay? This is going to start to indicate there's something going on. 4 is very brisk, is hyperactive with clonus, and this is going to be indicative of a disease process. Some other reflexes, we have the Babinski's reflex. With the reflex hammer or an object, you are going to draw a J pattern on the foot in an upside down motion, meaning you're going to draw an upside down J. Start at the heel and go up toward the toes. The normal response, what we're looking for is a negative Babinski's. The toes are going to flex downward. An abnormal finding is going to be a positive Babinski's reflex. The toes are going to fan out and the big toe is going to flex upward. This can be a sign or indication of brain damage. Corneal reflex. With the patient looking upward, you are going to have a cotton swab or something, and you are going to lightly touch the cornea, not the conjunctiva, but the cornea. And what we're looking for is we're looking for that person to blink, and they need to blink bilaterally for this to be a normal finding. If they do not blink, this is abnormal, and again, this can be a sign or indicator of some brain damage. Glasgow Coma Scale. This is a scale that we use to rate someone's level of consciousness. Scores range from 3 to 15 points. The higher the score, the greater the level of consciousness. A score of 15, they're fully alert. A score of less than 7 or less, is going to indicate that they are in a coma. Things we need to remember when we are assessing our older adults. Their movement and response time is going to slow down with age. So that may be a normal finding. So you always have to look at the age of your client. Their gait may be a little more slower, a little more deliberate. They may have to use some sort of device when they walk. They are at a greater risk of falls. So you want to be careful when you are in the clinic or hospital setting that the area is clear and that they have their device for walking. Their muscle tone and strength is going to decrease. Those rapid alternating movements, that's going to be more difficult for them to perform. And they may even have some tremors that occur, and these are called senile tremors. And this isn't actually a normal finding. Some abnormal muscle movements, paralysis. This is loss of the motor power. It can be due to problems with the nerves or muscles. It can be caused by trauma, or it can be caused by a disease process or an illness. Fasciculation. This is rapid, continuous twitching of a muscle that is resting. It can be seen and it can be palpated. Tics are involuntary, compulsive, and repetitive twitching of a muscle group. Myoclonus, this is rapid, sudden jerking at irregular intervals. And a tremor, involuntary contraction of opposing muscle groups. There's two types. We have a resting tremor. This occurs when the muscle is at rest, and it will disappear when there is movement. Intentional tremor occurs with voluntary movement toward an object. Postures, abnormal movement to physical stimulation. This can be indicative of a severe brain injury. We have decorticate. Decorticate is when the upper extremities, the arms flex along with the wrist and fingers. The arms adduct tight against the thorax. The lower extremities are going to extend, internal rotation. Then we have decerebate. Upper extremities are very stiff, extended. They are adducted with internal rotation. Palms are pronated. Lower extremities are stiff, extended. Teeth can be clenched, hyperextended back, and plantar flexion.